check. Good evening, everybody. Good evening. My name is Russell Judd, and I'm the Chief Executive Officer of Kern Medical, and would like to welcome you to this evening to our forum on Valley Fever. It's a great honor for me to represent the Valley Fever Institute. As many of you know, Kern Medical and many of the physicians associated with us and in the community have been treating the disease of valley fever and doing all that they could as far as with research and direction to deal with this devastating disease that affects our community. As we begin this forum this evening, it's very proud of us to talk about the Valley Fever Institute, an organization that we formed to finally bring all of the resources of the community, of Kern Medical, of the research that is done across the nation into a academically based central organization that has a very clear and defined mission in regards to valley fever. We have three aspects that the Valley Fever Institute focuses on. One is education for patients as well as providers. That's why we're here tonight, fulfilling our goal of educating as many providers as we can about valley fever. Of course, to treat patients, give state-of-the-art care to those who suffer from the disease, and of course, the research arm, whether the pathway of finding a vaccine, the pathway of finding a cure, doing all that we can to advance the research on valley fever. We're very proud of the team that we continue to build and put together on the research side, on the education side, and as well, of course, as treating those patients. We're very excited about the funding that is coming. The seed money of the start of this Valley Fever Institute came from the state of California in our last budget round, where the state of California is beginning to recognize the significance of this disease and making an investment in this and our approach to this disease. We anticipate that more will be coming. We're very anxious of some stuff that's happening on the federal level to get the financial resources that are necessary to do all that we can in the treatment of valley fever. So we've been planning this event. We're grateful for your attendance. I think you'll find it very educational clinically, as the clinicians who deal with this on a very regular basis can provide the latest updates and the focus on what we're doing with valley fever. As we begin tonight, I want to make an introduction. A very good friend to all of us, a very clear advocate for valley fever, and that is the House Minority Leader, Mr. Kevin McCarthy. He couldn't be here tonight. He's not walking in the door. Got you excited there for a little bit there, didn't I? But he has taken some time. We have a video from Kevin. Again, we know the value that he creates as our representative. And I can tell you, I was just in Washington, D.C. A couple of weeks ago. Dr. Johnson and I, he had 6 congressmen in his office advocating for valley fever, rallying up that opportunity and that support. Great supporter of our community and a great supporter of valley fever. So with that, the Honorable Kevin McCarthy, and then we'll proceed from there. Thank you.
Good evening, and welcome to Kern Medical's Valley Fever Symposium. Your participation tonight is vital in spreading the awareness of a disease that impacts our community like few others in America. Since our first Valley Fever Symposium, the NIH has funded millions of dollars in valley fever research, including the current observational study, to help us better understand who gets this disease and how to best treat it. We need your help in making this study a success by encouraging your patients to participate. I want to thank Dr. Royce Johnson for leading the medical team at the Valley Fever Institute, and Russell Judd for his leadership in making this evening possible. Together, I'm confident that we are turning the page and making progress on this devastating disease. Thank you, and God bless.
We'll now kind of proceed. Salads have been served. Thank you, most of you, for getting started. We'll take a few minutes as dinner is served, and once we kind of get that settled, we'll begin with the presentation. So visit amongst yourselves, and we'll move quickly to get dinner served and then on to the speakers. Thank you.
is? I can't hear it. Good evening. Is it on? No, it's not on. Good evening. I know all of you are enjoying our dinner, but I'd like to have your attention. I think we have a lot to accomplish this evening, and I think it's important. So I think we need to get at it. As most of you probably know, I'm Royce Johnson. I am going to give the first talk, and I'm also going to moderate tonight. So I want to welcome all of you here. I'm impressed with so many of you gave time from your busy lives to learn about what Dr. Einstein called our fungus. So without further ado, I will also point out that some of my slides actually came from Dr. Einstein. Where do I point this? So that's who I am. That's what we're going to talk about, but I can't make the slides move. Point down? Oh, the other direction? Oh, okay. Nope, not going.
Is it turned on? Try that. Try it again. Try it again.
Isn't this?
Yep.
Wait a minute. The light's not on.
No, it's okay.
And this arrow or that arrow?
Try that.
I guess it's working. We'll see. So this handsome creature, and I apologize to some of you for this being at dinner, is the very first reported case of coccidioidomycosis by Wernicke and Posadas, Buenos Aires, the middle of the last decade of the 19th century. And they thought they had found an infectious cause of mycosis fungoides, but in fact this is the first reported case of coccidioidomycosis. Subsequently in San Francisco, Rixford and Gilchrist found the second case. You notice both of these were skin diseases. Both of these chaps died. We didn't really understand valley fever, meaning the pneumonia, the primary disease, until the work of Myrnie Gifford, who was a physician at the health department, the Kern County Public Health Department in the 30s. She and her mentor Dixon, between them, figured out that valley fever, which was well known to local people, but they didn't know the cause of it, was in fact the primary illness associated with coccidioidomycosis. Subsequently, Opfels at Stanford worked out the life cycle of the disease and figured out that it lived in the soil and that you breathed it in and it caused pneumonia and then subsequently could move to other parts of the body as disseminated disease. We really had no therapy for the disease until Hans Einstein in the 50s developed amphotericin. Primarily, its original use was for valley fever. So the organism does grow in the soil. It is not widely distributed. It's in little patches. It's difficult to find in the soil. We actually have people here from Cal State that can tell you how hard. When it grows in the soil or on an auger plate, it's a mycelium. Looks like this. It produces arthroconidia. These are spores that grow up out of the soil or out of the media in your laboratory, a very dangerous thing to do, I might add. They break off, and in winds like yesterday, they blow around. They can go 75 miles. You inhale it, and you have valley fever. When it's in your body anywhere, it produces a different morphoform, hence it's called dimorphic, and you get spherules with endospores, shown here. So this is the life cycle of coccidioidomycosis. On the left is the dirt cycle, if you will, and on the right is the animal cycle, because Coxy certainly infects people and all other mammals are potential patients, as it were. This is the world map of coccidioidomycosis. You notice we left out Europe, Asia, Africa, a few other small places. because there is no valley fever outside the Western Hemisphere. We have the dubious distinction of having one of the highest levels of endemicity, and we share that with our colleagues in Tucson. As you move north from here or south, the frequency of the disease decreases, and that's similar in Tucson as well. Of course, northwest Mexico is actually heavily impacted as well. But there really is Coxy in the whole Southwest. And for instance, our colleagues in Texas, they don't report the illness, so we actually don't know what happens there much at all. So this gives some idea of the variability of how many cases there are per year. And you can see there was a huge epidemic in the early 90s in Kern County. And more recently, we've had, if you draw a line across those bars on the right-hand side of the graph, you'll see that it looks like we have nothing but increase on average. How do you diagnose this disease? There is a skin test that's available. It's not used much. That's largely an economic thing, and also skin tests require 2 visits, and modern people don't like 2 visits. There's also serology, which I'll talk about a bit more. You can culture Coxy with difficulty from various places. You can use histopathology. It is extremely important that the histopathology is read correctly. And you can use culture. But again, I've seen substantial mistakes made in certain laboratories with the culture. So all of this requires a certain level of expertise that is not universally available. So this shows Coxy serology in the sense of IgM and IgG antibodies. First IgM antibodies come up, subsequently IgG antibodies, not like most every other infection that has an antibody response. It can take up to 6 or 7 weeks, however, before antibodies appear. Which kind of antibody, what are the tests that we can do? On the screen, there's a variety of tests. I'm not going to go into great detail. I will say this, that most of us that love this field do not like the EIA test a lot. We particularly don't like the Marion EIA test a lot. The MEI test, EIA test is probably somewhat better, and the EIA test done at the inconveniently located Mira Vista Diagnostic Laboratories in Indianapolis, Indiana, is probably the best. So we really rely on the immunodiffusion, IgM and IgG, for both sensitivity and specificity, as performed only in 2 laboratories, the Kern County Public Health Department and UC Davis. And both of those laboratories also perform Coxy complement fixation, which is sort of our definitive test that we use for both diagnosis and prognosis and treatment response. The height of the titer is talked about a lot. The unfortunate truth is you can have horrible disease with a titer at 1 to 4, and you can have no illness whatsoever with a titer of 1 to 512. However, if you take a population, the ones with the high titer have the worst disease, particularly extrameningeal disease, as is shown on this slide by C.E. Smith. And notice the enormous overlap between the 3 groups. So in any given person, the titer doesn't tell you how sick they are or where their disease is. There's a lot about immunology. I made this slide up years ago, and I was proud of it. Now I think it's a horrible slide, but I'm showing it to you anyway, because I figured out that the delayed hypersensitivity actually has 1,000 parts. It's not just a word, and that we don't understand it at all well. And so the more I've studied it, the more I've learned, the more I figured out that we actually still don't know what's going on. But the point being that probably the reason you don't do well with this disease has to do with your host genetics. I have doubts that it has to do with different strains of the organism. So it's the host that determines the outcome of the infection. And I think it's going to be an incredibly complicated story. And I won't go into that in more detail. By the way, often when I'm giving a talk, I invite people to interrupt me. And I see 2 or 3 people in the audience that I know really want to. But we'll try to hold the questions toward the end because we have so many things to get over today. So I'm not going to talk about pulmonary coccidioidomycosis in any substantial detail at all because Rasha Karan's going to do that in a few minutes, so I think we'll pass through this. And I will talk about the symptoms, only to mention that there are some, and this is from a study we did in 435 patients in, well, actually this says 500, I guess it was 535 patients. We didn't have complete data on all of them, so you see different numbers on different slides. So this was half of the people that got Coxy from September 1, 1991 to December 31, 1991 in Kern County. So these patients were all Kern County patients, and there were about 950 patients in that 3-month window, and that was the beginning of that big spike I showed you a few slides back. And these are the symptoms they had, outpatient and inpatient. Most of these were from large centers as opposed to private individual practices, but we collected these people, we followed them for a year. That was a $50,000 grant from Pfizer, I might add. Boy, you wouldn't do it for $50,000 today. And these are more symptoms of primary disease, but I'll leave that to Rasha. This is a pneumonia. Oh, maybe I go back on that. This is a pneumonia. I think she has the same slide. She'll talk about it more. You could diagnose Coxy from this X-ray, but mostly you can't. And I won't talk about that. I will mention erythema nodosum. Erythema nodosum can be caused by a whole variety of things, but if you see a patient with a pneumonic illness in Kern County, erythema nodosum means you have Coxy. It can be TB, it can be group A strep, it can be sarcoidosis, but it almost never is. This is Erythema Multiforme. This does actually occur with a lot of things, including drugs, but it can be a hallmark of coccidioidomycosis, primary disease, mostly in children, and that is a child, as you'll see. And this is pleural effusion. So pleural effusion is part of primary disease, and I don't remember whether Rosh is talking about this, so I won't talk any more about that. This is primary cutaneous coccidioidomycosis. Quite rare. So 99% of people that have Coxy got it through their lung, no matter where it ends up. Whether it ends up in the meninges or the foot or wherever it is, it started in the lung. But you can get it by scraping your skin along the dirt. So this is a woman that lived in Los Angeles, but one of her hobbies was fishing in Bakersfield. And she made a small mistake while fishing. What was that? She didn't wear shoes. And she got Coxy in her big toe, so that's her primary infection. And then it disseminated, she developed meningitis, and she died. Solitary pulmonary nodule, this is really more Dr. Munoz's territory than mine. This slide was actually made by Vince Phillips when he was a surgery resident at Kern Medical some long years ago. I'm not going to go through this. But solitary pulmonary nodule is actually very different in Kern County because of coccidioidomycosis. If you go to Boston or to UC Davis even, solitary pulmonary nodule in a middle-aged man is almost always cancer. In Kern County, 3 out of 4 times it's Coxy, which is a much better thing to have than cancer, I gotta tell you. So it's a very different subject here. And this is also a picture that my partner, Augie Munoz, who perversely is going to talk about OB Coxy tonight, but he's our bronchoscopist par excellence. He took this picture a long time ago of airway Coxy. And this is a cavity. I won't spend more time. This is silico coccidioidomycosis. This is a chap that worked in a kitty litter factory, which is diatomaceous earth, which is silica, which injures your lung, and then he got Coxy on top of it. And he didn't die of Coxy, but he died of pulmonary hypertension at 27. As you can see, this is a bad chest x-ray. Even for those of you that don't know anything about x-rays, remember they're supposed to be mostly black. When they're mostly white, you have to phone Houston and say you have trouble. This woman obviously ended up on a ventilator and had a positive blood culture. She had meningitis, but she died of respiratory failure. Disseminated disease, these are the risk factors. High CF titer is a risk factor. African American ethnicity is a risk factor. Age over 50, I'm sort of annoyed by that one. Adenopathy on chest x-ray. Actually, male sex, I'm also annoyed about that one, are all risk factors for dissemination. This is again part of the data from that study. Where does Coxy go when it leaves your lung, or your toe for that matter? And the answer is any place it wants to. Any place it wants to. Coxy has been diagnosed absolutely everywhere. When Dr. Trang, our ENT surgeon, came to town, I told him that the only place I had never heard or seen Coxy was the sinuses. And one day, a year and a half or so later, he called me from Memorial and said, scratch that one from your list. So it prefers, I guess I could go back, bone, joint, skin, and meninges are the favorite places. But it can go to eye, fallopian tube, the outside of it can be peritonitis, it can be anywhere it wants. So this handsome young man is 7 years old, so that's probably not acne. What do you think? Yeah, that's Coxy of the skin. You wouldn't know it from looking at that. Maybe there's a dermatologist here that would say, yeah, I could tell that, but I can't. But if you look at his knee, that's a classic granuloma. That almost has to be a granulomatous disease. And again, in our neighborhood, that would be Coxy, and it was. This is a picture of my partner. Well, that's not a picture of my partner. It's a picture of a patient of my partner, Dr. Haidari. And he and I have, I think, 3 of these cases between us now, maybe more. And we call this zostiform Coxy. I have no idea why it looks like this, but it's sort of reminiscent of a zoster. And again, this probably has an immune reason that it looks this strange way. This is very unusual. This is the forehead of a young man that I knew when he was in high school that subsequently became a physician. That's cutaneous Coxy. This is a list of the bones that it goes to. You'll see it's a pretty inclusive list. I forget how many bones we have. What is it, 205? Yeah, it can go to every one of them. But it loves the spine, loves the spine. And this little girl has it in her finger. This is a picture that Dr. Einstein gave me. This is a picture from 1949. That's even before Einstein, for those of you that believe there is anything before Einstein. Hard to believe, but he got this picture. So in 1949, we had no amphotericin, we had no fluconazole, we had no nothing. So they amputated this little girl's finger, and she did well. She grew up, she got married, she had 2 children, and she was killed in an automobile accident at age 27. At autopsy, I know none of you have heard of doing one of those except on television in recent times, but she had an autopsy, and they cultured the lymph nodes from her mediastinum, and it grew Coxy. Coxy is forever. This is a young Arabic man who had a sore shoulder and a positive Coxy serology. The x-ray of that shoulder, I was young and very aggressive in those days, was actually negative, but I told the orthopedic surgeons they had to go in and get me a biopsy. They went in, you can see the scar on his left shoulder, and they came out of the operating room and said, you sent us on a wild goose chase, there was nothing in there. And I said, oh, sorry. But then he came back to clinic, and this thing was growing out of his shoulder. And I didn't speak Arabic too well, so I don't know what all he thought about this, but it may not have been good. Any rate, what does that look like? It looks like a mushroom. And what phylum is a mushroom in? It's a fungus. I've always thought of Coxy that this was sticking its tongue out at me, sort of. At any rate, he got treated. There was Coxy in his shoulder. He got treated for it, and he did well. This is an infection in the bone. It looks like it's in the skin, but it's the bone of the hand. This is a woman that you might think is pregnant, but that's not a pregnant abdomen. That's a collection of fluid under her abdominal wall that has dissected around from her spine, where she had an infection, anteriorly. And that's osteomyelitis of the lumbar spine. And there's a picture of the lumbar spine. And there's a bone scan. She also had it in her knee, and eventually other places as well. And that's a bad Coxy pneumonia. And Dr. Haidari is going to talk about this subject. A few days later, that was her brain. Obviously, she didn't do well either. So, antifungal treatment. I know Rosh is going to talk about this, but there is a substantial disagreement about who should be treated. Particularly, there's a schism between California and Arizona. People in Arizona are tougher than we are here. They don't treat people we would definitely treat. So clearly everybody with disseminated disease gets treated. People with meningitis get treated the rest of their life. The argument largely revolves around which primary disease you're going to treat, and I'll leave that to Rasha to talk about more. And the antifungal drug we'd like would be one that meets all these criteria. I'm not going to go into this. You can read them quickly because I won't give you much time. But what we want is an antifungal drug that kills Coxy. We don't have one. None of them. The treatments hold the fungus still, and we hope your immune system gets around to developing a way to control the fungus. And so I've developed the term, although I didn't originate it, I thought I did, but my daughter proved I was wrong, of Immuno Plasticity. Immuno Plasticity. Because the patients we treat are clearly not the people whose immune system knocked this down, because 60% of people that get infected don't have any symptoms. So the people that develop disease, I view them all as having some perturbation of immune response. And the goal of treatment, it occurs to me, is to wait until their immune system gets around to doing the job that it didn't do originally. Immunoplasticity. So treatment is azoles, and we'll talk about these briefly. We can go into it in more detail when we have our question and answer session at the end. Polyenes, meaning IV drugs. And there's new drugs out there, but they're not getting studied much. There's a long story that goes with the drug nicomycin Z, which was actually invented in 1984, but hasn't seen the light of day. We would love to have that drug in our armamentarium, I think, but I don't know how much. Somewhere between 200 million and $1 billion short of having that happen. Any of you who would like to leave a check with me at the end of dinner, I'd be happy to forward it to my colleagues that are working on this. So this is the names of the drugs that we use. So by and large, amphotericin B deoxycholate is not used IV anymore, but that's still what we use intrathecally. We don't use ketoconazole, but we do use fluconazole as our predominant drug, and we also use itraconazole, voriconazole, posaconazole, and isovuconazole. We're trying not to use voriconazole, however, because of the phototoxicity and other problems with dosing it. And the big problem with these drugs, they're not, the patients don't necessarily agree with me on this, but they're not particularly toxic, most of them, with the possible exception of Vori, but they're extremely expensive. So posaconazole is $4,000 a month. And if you're on it for meningitis, that means it's $4,000 a month for the rest of your life. I'll skip that. Well, at least Dr. Haidari is going to talk about this a bit. And these are the side effects of that. So we get to this handsome chap. You remember the two guys at the beginning? Yeah, well, this is one of our patients in the not-so-distant past. So we clearly are not where we want to be with treating this disease when we have patients that have this appearance. I think you can agree. So thank you very much for your attention. We won't do questions now. And next, I would like to introduce the newest member of the Valley Fever Institute medical team, Rasha Karan, to talk about pneumonia. Rasha?
Thank you.
So it's this button.
Okay, got it.
Leave this here for me.
Thank you. Not as tall. Okay. Again, I'm Rasha Karan, and I'm thrilled and honored to have just recently joined, about 2 months ago, joined the faculty at Kern Medical and the Valley Fever Institute. And I will be speaking about pulmonary cocci versus community-acquired pneumonia. So, as Dr. Johnson mentioned, we get pulmonary cocci after inhaling the arthroconidia from the soil, and therefore the first place that it gets to is the lung, and that's why it usually presents as a pneumonia that's almost indistinguishable from community-acquired pneumonia in presentation. So how do we tell them apart? If you look at everybody who acquires the infection, the majority, about 60%, will actually not even know that they had the infection, and they will go on to become immune without ever going to the doctor or acquiring or presenting with symptoms. And only 40% will have symptoms. And out of those, a small percentage, up to 5%, will have either severe disease or dissemination. But most of those patients, the 40%, will present as community-acquired pneumonia. So the really striking, the impressive fact is that, I'm going up now, here. If you look at everybody diagnosed with community-acquired pneumonia, every 30%, up to 30% of our patients diagnosed with pneumonia actually have Coxy. And this is in highly endemic areas, such as the area we live in. So that's a pretty high percentage. And it takes 7 to 21 days to get the symptoms. And why is that important? Why is it important to detect everybody and diagnose everybody who has acute pulmonary cocci, even if they're not going to be very severe? It's because we now know that the risk for complications has nothing to do, is not related to severity or initial presentation. So it would be really a good idea to follow those patients in case they develop severe symptoms or have problems later on. And this is the slide that Dr. Johnson had showed earlier. It's a nice study that was performed by Dr. Johnson and others. They looked at 521 patients to study their symptoms, initial presenting symptoms. And as you could see, the majority came in with cough and fever. They're just 2 slides. Pulmonary symptoms included cough, chest pain, shortness of breath, sputum production, erythema nodosum rash, and fever, chills, night sweats, headache, fatigue, and myalgia. So very similar to community-acquired pneumonia. This is why, the rash is why in the past this used to be called desert rheumatism, which is the triad of fever, rash, and migratory arthralgia. This is before they knew that it was an infection. Other historic clues from history, patients can also have weight loss, and non-meningeal patients can also present with headaches up to 21% of the time, and they typically would not improve with antibiotic therapy. And it would be nice to diagnose them early also, because we don't want to expose people to more unnecessary antibiotics, and that's another benefit of really catching them early on. So you do labs, you'll usually find unremarkable. The labs are going to be not much different, except for serum procalcitonin is a nice tool that we have nowadays, and this usually would be normal in Coxy patients and elevated usually in pneumonia, bacterial pneumonia patients, not viral but bacterial pneumonia. And then usually the ESR is elevated 1 to 2 times above upper limits of normal, but that would be also the case possibly in bacterial pneumonia, and the white count will be elevated. This is a big difference that with Coxy we see more eosinophilia, and up to 1/4 of patients will have elevated eosinophil count. That's kind of specific for Coxy. And then you do an X-ray. I borrowed this slide from Dr. Johnson as well. So if you look at everybody, 13.8% of patients will have a normal chest X-ray on presentation, and 87% will have an abnormal chest X-ray. Out of those, the most common finding would be an infiltrate, most commonly right upper lobe. But they could also have an infiltrate with ipsilateral adenopathy, meaning on the same side, or infiltrate with an effusion. Infusions tend to be more on the left side. So this is the classic presentation, unilateral infiltrate with ipsilateral hilar lymphadenopathy, and this is the most common radiologic presentation, infiltrate and the lymphadenopathy on the same side. So how do we diagnose it? Dr. Johnson went over testing with serology, preferably with immunodiffusion, and then complement fixation titers. It really is definitely more accurate, and actually only accurate if it's done at the laboratory, reference laboratories we use, the Public Health Department and UC Davis. We've had many cases where the case is confused simply because the laboratory test is done elsewhere, and all it takes is just doing the test at the right laboratory, and things become more clear. And that's a very common challenge we have when we look at Coxy patients in town. So how does pulmonary Coxy present? The majority of patients present as primary pulmonary, primary pulmonary Coxy, uncomplicated. And those out of the symptomatic ones, it's either influenza-like pneumonia or pleural disease, and then they could less commonly present as complicated. And then some of them will go on to have residual or residual pulmonary Coxy or complicated pulmonary Coxy. What are the risk factors for severe pulmonary disease? Diabetes, smoking, low socioeconomic status, older age, cellular immunosuppression like AIDS and arthritis treatments. And then the last one is actually a favorable factor. Patients who have been treated with antifungals prior to presentation have a better, less risk of severe pneumonia. Now, out of the complicated and residual pulmonary Coxy, initially the ones that do poorly are the ones with diffuse disease, and those could usually will have can have respiratory failure. Now, those are the patients who get diffuse disease either because they have inhaled a large inoculum, or because they are immunocompromised and they develop fungemia, so they have miliary pattern. Both can do really can be very sick, and those are the ones that would need to be treated with amphotericin. We'll talk about that in a bit. So in AIDS patients, less than 100 CD4 is about a third of them will have this pattern on presentation. And then this is an example of diffuse or miliary disease. Oops. You can have cavities, you can have empyema, you can have a nodule, and we'll talk about them, or progressive fibrocavitary Coxy. So when it comes to therapy of each one of them, can't see from here, so I have to look at my slides. First question would be, who are we going to treat? Who needs to be treated? And then we need to select the appropriate antifungal agent, and then decide sometimes if the patient needs surgery or not. And as Dr. Johnson mentioned, the people in different areas have different practices. If you look at the IDSA guidelines, or you look at the guidelines coming out of Arizona, they're different than ours. We tend to treat everybody who has active infection. I listed some of the ones that are mentioned, but we really tend to, everybody who's symptomatic and presents to us until their Coxy titer is less than 1 to 2, because we see how, if we do not, bad outcome that would result if for those who are not treated. So we treat them until they are symptomatically better and radiologically improved, and then their titers are back to almost negative. But technically, the ones who are not really sick, they don't get treated, but high CF titer, and again, this has, this is taken into in conjunction with other factors. And then progressive disease, patients who are symptomatic, they can't do work, or losing weight. But again, what we do here is we treat people who are symptomatic until they're better. And Dr. Johnson touched on antifungals. We usually treat pulmonary disease either with azoles, polyenes, or there are new drugs. Azoles are the most commonly used medications. Fluconazole is the most commonly used one. We start with 800 milligrams a day for adults, and we check levels on all of them. We tell the patients who are females that they either should take precautions not to get pregnant, and if they plan to get pregnant, they need to tell us no, because we don't want to be treating them with azoles if they're pregnant. And then we always want to look at drug interactions and risk of QT prolongation. So we study patients' medication before we start it. Ketoconazole is not really used; is not used anymore. Itraconazole has really good outcomes when it comes to bone and skeletal disease. And then voriconazole is another option that you can use. The side effect profile, though, is more severe than fluconazole, especially with the dermatologic side effects. And then posaconazole, izavuconazole are the newer ones. Polyenes like amphotericin B are the other group, the second group, and they are indicated when patients have hypoxic lung disease or severe lung disease, and in that case we have to add steroids. For hypoxic patients, you want to give them steroid, and it's usually similar to the taper that is used with PCP pneumonia, and so that is associated with less mortality for sure. So also critical bone disease and pregnancy, those are the indications for amphotericin. Sometimes with failure, progressive disease despite azole therapy, we can also consider amphotericin. Now, with uncomplicated pulmonary disease requiring therapy, it's usually 3 to 6 months. However, we follow the titers until they are down, and we wait until the patient is no longer symptomatic, and radiographically there are no active infiltrates. So for diffuse pneumonia, the one that's with high inoculum or immunosuppressed patients, we start with polyenes for several weeks, and then along with steroids, and then followed by azoles for at least a year, and sometimes obviously longer if needed, and we follow CF titers and radiology, obviously. For chronic fibrocavitary disease, those patients respond less often, and you could try to switch azoles and use amphotericin if the disease is severe or worsening despite azoles. And sometimes those patients can benefit from some surgical intervention, but they're tougher to treat than the simple pulmonary disease. Pulmonary cavities, they're usually thin-walled. Usually they can have a fluid level in them or not. 90% of them are single, 70% are peripheral in the upper lobe. They're usually 2 to 4 centimeters in size. We call them giant if they're more than 6 or 5 sometimes. 30 to 50% resolve spontaneously in 1 to 4 years. Those, especially those that are less than 2.5 centimeters, and the ones more than 5 usually persist. And usually they're asymptomatic, but sometimes they can produce symptoms. The symptoms can be hemoptysis, cough, fever, localized chest pain, night sweat, weight loss. And they can produce complications, including a fungus ball. And that fungus ball could be with Coxy or another fungus like Aspergillus. They could also have bacterial superinfection. And most seriously, they can rupture into the pleural cavity and cause an empyema. Therapy for cavitary disease, for cavity, pulmonary cavity. Usually, if the patient doesn't have active disease and they're asymptomatic, and the titers are okay, you can observe them. But these are the indications for surgery. If they're expanding rapidly, if they are close to the visceral pleura, almost going to rupture, if the patient has serious or persistent hemoptysis or has a fistula, or the patient has a long-standing cavity with chronically positive sputa. The Coxy keeps growing from the cavity. Now, after we treat the patients, we will follow them, and that's what we would recommend, is follow them for up to 2 years after we finish therapy or from the date of infection, whichever one is later. So, because most of the time, if disease reactivates it or shows up again, it would show up within the 2 years after we stop the medications. And so during that period of time, we follow the patients intermittently, more frequently initially and less later on, or if they develop symptoms. And we follow them up with symptoms and serology, and we check on them until 2 years have passed. And then we don't follow them anymore. And that's my talk. Now I would like to welcome Dr. Arash Hideri, who will, who will speak about Coxy Meningitis.
Give us like 3 minutes. We're getting your screen.
Really? Oh, wow. Okay. Very good. Hello, everybody. My name is Arash Hideri. I'm one of the ID doctors at Kern Medical. I have the pleasure of being here in front of you. I just want to first thank you, all of you, of believing in us and sending your patients to us. Without you sending your patients to us, we don't have no research, we have no projects, we have no activities, so there will be no talk, no guideline, nothing. So you're a part of this. I've been trying to learn from the best. Some of them are here, some of them passed, like Dr. Einstein, and I'm being at the best place to learn this for the last 20 years. So I have no disclosures, unfortunately. Just being at the Kern Medical on salary. How about that? So, any CME needs to have a question, otherwise you will not be credited for CME. So, I hijacked this case from the American College of Physicians self-assessment. I have 3 residents in the audience. I'm not promoting, so I'm not going to charge them. It's a 27-year-old man with 1-month fever, drenching night sweats, malaise, fatigue, chest pain, non-productive cough, received 7 days of Levoquin. Hopefully his aorta is not popping. He is in the military, works as a car mechanic and base, and he's stationed in Bakersfield, California. Believe it or not, American College of Physicians, for the first time, putting a question as a board question practice And they're not putting Arizona. So that's definitely an improvement already. So physical exam is not that impressive, except respiratory rate being high, O2 sat being low, so he's hypoxic. He is, sure, they want me to talk to the mic. And the exam otherwise is normal. So he's a little anemic, maybe for male. White count is not high, but as you can see, the eosinophilia, 30%. Chest X-ray shows right lower lobe. You've seen so many last 2 lectures. And hilar adenopathy, we call it. Which of the following is the most likely diagnosis? Audience, please. Wow, coccidioidomycosis. CME is credited, now you can leave. But you diagnosed with pulmonary cocci. I was trying to test you how much you gained from Dr. Kuran's lecture. You're sending for serology, you start him on a fluconazole, high dose hopefully, not like Arizona people. But you're trying to sign your note, and all of a sudden you see your medical assistant clicked on a positive headache in the review of system. Oh my God, it shows up on the side of your electronic medical record. What am I gonna do now? Should I Google headache and Coxy? Should I call him and get a better history, arrange for LP, do an MRI, increase dose of medications, get an ID consult, let Dr. Johnson to handle it, or I'm just here for CME and dinner? Which one? Very good. So you chose to Google, of course. So people at the CDC agrees with you that the primary Coxy, one of the symptoms, you see them all, could be headache. So is this just primary or is dissemination? I don't know which one. So our people in Arizona, this is their logo on the middle, also agrees that headache is definitely could be one of the symptoms. And of course, you have paid for your up-to-date. Everybody has it. And then, as you can see, the headache was seen in 27% of the people with the primary Coxy. By the way, if my microphone stops working, it has nothing to do with the audio-visual. It's Dr. Johnson's have a frequency jammer, so I don't teach you nothing wrong. So you search more because you have extra time that night. And then you find this a study from 1970s because it's published in New England Journal of Medicine, should be good. And then a group of archaeologist students was sent to the center. They did not know that was actually a site of Coxy. 61 of them got Coxy. But about 50 or 61, look at the arrows, you don't want to read the rest of it, had headache. And it is not mentioned that which one of them had meningitis. So we know headache is actually one of the symptoms of valley fever. So you might feel a little better now. Okay, maybe I should not do nothing. Then you search more because you have definitely more time to do that. And you come up with this case. The CM was his initial. Is a 19-year-old canner, used to be a job. Was admitted to the county hospital in San Francisco on September 23rd. I'm going to go back to this date for some reason. With 4 weeks of irregular fever and violent chills. He had stopped in, again, Bakersfield for 12 days prior to come to the San Francisco. He developed much of a headache with marked rigidity of the neck. He is becoming confused and delirious. He had a complete paralysis of the 6th nerve. He can't look at the side. And he died 3 months later in the hospital, unfortunately. So now you're very nervous. Of course, they used to call it narcopsy, was done. And you see Basilar Meningitis, nodules in the sylvian fissure, extensive inflammation of the pia mater and spinal cord with thickening, which we call it arachnoiditis, and nodules and abscesses. This case is published in JAMA 1901. So 100 years ago. So what are the differential diagnoses of headache? You're really nervous. Maybe it's a part of primary. Infectious Disease Society of America coming up with a number, 21%, close to up to date, so it's worth buying it now, you know. Adverse reactions after medications. Believe it or not, your medication can cause headache. Fluconazole up to 13, posaconazole up to 28%, and this is in a package insert. And even I save you this Kunazole, whatever it is, I save you Conazole. I saved you to the last, 17%. It's in the package insert. So some people will get fever and cough. They get headache at the same time. Or is this dissemination to the brain? That is the nerve-wracking part. So when to do lumbar puncture? That is the time to make a decision. If the headache is the predominant symptoms, if they come with a headache, they always say, but how about my headache? If it's more than a week, this is from the Infectious Disease Society of America guidelines. I did not make this. Unusual worsening. If they're confused, they have nausea, vomiting. That's not good. If they have anything that tells me some part of the brain is not working, it's a neurological deficit. So you have to be nervous. So diagnosis of Coxy Meningitis is based on lumbar puncture and MRI. So they needs to be done. The headache is always present. So now you're at the odds of calling it something else versus headache. It's from meningitis, I don't know which one. Mostly male, up to 4 to 5 times more than female. Maybe it's because of exposure. Common in Caucasians. This is Dr. Johnson's data in 1984. So you do a lumbar puncture, you measure opening pressure. It's a must, please. If you send it for current radiology, Truxton radiology, whatever radiology, they have to give you opening pressure, if you have to do it yourself. Because if it's elevated, that could be consequences of complications of this disease, which is devastating, can make your patient blind if you don't pay attention to it. So you will see that the white blood cell goes up. You call it pilocytosis. It could be at the beginning PMNs, but eventually becomes lymphocytic. Sugar is low. That's definitely a hallmark. If you see any meningitis, you don't know the diagnosis, the sugar is low in Kern County, that's valley fever. Could be TB also. So you might even treat both of them at the beginning. Protein is high, more than 150. If it goes above 1,000, that means this patient has some type of obstruction. Lumbar is lower, obstruction, dirtier, higher protein. That's how you remember. As sugar has been used, eaten up. That's how you remember. So serology is positive for Coxy meningitis, and of course we emphasized again on immunodiffusion and complement fixation. You might see the fungus under the microscope. If the patient has shunt, you might see the mycelia, because it grows inside the shunt, so you can actually see the mycelia. Spherical under the microscope in CSF is very rare, but the culture might grow. And we have a patient that is growing Coxy after how many years of treatment, Dr. Johnson? I think 30 years, is still there. Still shows up in the fungal culture. So, and then there are some antigen tests that they're trying to promote that. And also there's a PCR, there are case studies, but it's not common in practice yet. But they're coming. MRI is definitely one of the good things that you guys have to order, please. 50% of time you might see something, so you're not wasting the money. You might see the hydrocephalus, the consequences of increased ICP or increased pressure. You might see basilar meningitis. Basilar vasculitic infarct is not uncommon, so they must show up as a CVA in a young individual who works in the field. They don't have regular stroke. There is something going on. They might see abscess or some lesions. Some people used to call it coccidioidoma. So, the manifestations of Coxy meningitis is called leptomeningitis, which is basically enhancement of the brain. Meningoencephalitis, hydrocephalus, increase of the ventricle size. You might see a granuloma or abscess inside the brain. You might see a subarachnoid vasculitic infarct from usually basilar area. And in the spinal cord, you might see some lesions called myopathy. Arachnoiditis is a thickening of the layer of the spine. Syrinx is basically just a tear inside the middle of the cord because the fluid is trying to find its way down because of obstruction, or some cystic lesions pushing on the cord and causing issues. Or sometimes you see the cranial nerve palsy as the presenting symptom. So these are some of the MRIs. These are all patients that you guys sent to us. They're all original pictures. I don't know which. I'm sorry, guys. I'm ignoring this side. I'm trying to. So the first patient has the hydrocephalus, as you can see, very enlarged ventricles. And the lower one also has hydrocephalus. As you can see, the fourth ventricle is pretty enlarged. It shows there's obstruction down below. This patient has classic basilar meningitis. I call it spider sign. This patient has a lesion right there. I put an arrow. This is probably a granuloma of the valley fever. This patient has speckles of granuloma. I call it shotgun sign. It's not published. It's all made up. This patient showed up one day, no headache, but has dissemination coxy with diplopia. And guess where is the lesion? Right sitting on between the two, the chiasma of the optic nerve. So this could be a presentation of a Coxy Meningitis. So comes down to the MRI of the spine. You might see cystic lesions pushing on the spine. This patient is paraplegic, unfortunately came to us too late. Treatment above it helped his brain, but treatment could not get below, so he remained, unfortunately, paraplegic. This patient has a lesion at the neck, is pushing toward the almost highest part of the spine. I remember a neurologist came and said, oh, she's going to become quadriplegic. She hasn't. She's using walker. Fortunately, treatment worked. This patient's spine is like a snake. He just went from one side to another side on that corner. This patient has an infection at the end of the spine called thecal sac. That's called arachnoiditis right there. This patient has inflammations of the leptomeningeal, the entire spine. No focal. And this patient just came in one day and said, I have neck pain. And there's a lesion sitting right there pushing on the C-spine cord. So these are some MRI findings that you might see in these patients. So I was trying to hijack some tables for treatment of Cox meningitis. There is no table, so I made one. So maybe this is a time that you want to write down some stuff if you want to, for the CME purpose. So treatment for Coxy meningitis, or you can use this one for even disseminated bad infections if you don't want to send them to the hospital. Fluconazole high dose, 800 to 1200. You like to measure the serum level. Should be above 30 for meningitis. That means they're taking it. That means it's getting there. If you have lower dose, it won't work. So that's why we follow. QT prolongation is a problem. Don't give them Z-Pak. Otherwise, you're going to get sued. Somebody will be in the hospital. Dry skin, Andre, yes? Dry skin? Hair loss? Fatigue? Shoulder pain. We have not published it. If your patient has shoulder pain, it's fluconazole. They can't raise their arms. It's definitely a known side effect in that dose. Itraconazole can be used. Doses are being there. You divide them. Make sure you have giving him something that is acidic. Otherwise, they will not absorb. Don't put him on acid blocker medications. If you do, they don't absorb and they disseminate it. They might get more complications. We would like to keep the level between 3 or 6. Remember, it comes at a regular dose and a hydroxy dose. You have to add them up to come up with that dose. It causes the same problem with the QT prolongation. Potassium goes down. Half of my patients on itraconazole are on potassium supplements. You have to be aware that this medication can cause heart failure. So if somebody is more than 50, you have to make sure that you get an echo and causes high blood pressure. Voriconazole we don't use, try to not to use, but sometimes we corner to use in meningitis, especially when the two of the others don't work. Usually dose is 4 milligram twice a day per kilogram. So usual dose is 200, 300, 400 twice a day. If you're doing lower dose, it's not working. And you measure the serum level exactly the same, like 3 to 6, that's what we think. We published this data, by the way. It causes QT prolongation, as Dr. Kuran mentioned, visual disturbance, everything turns yellow, and it goes away. It causes the skin manifestations called photodermatitis. The skin color changes. Any light bothers them, including this light into my face. And then causes the skin cancer, unfortunately, all kinds. So if you have a patient on voriconazole, you have to get them to the skin doctors twice a year at least, and use the best sunscreen that has the effect, which is Helioplex with ultra sheer. Neutrogena is one of the brands. I'm not, again, I have anything to disclose. But that's one that's been studied. Unfortunately, the effect of voriconazole causing cancer being a precancerous condition is permanent. So if you stop the treatment, they might get skin cancer in the future. So I have a patient who got a letter from me that he can have tinting his windows, even the side ones. He's afraid of the sun. He doesn't work during the day. I call him Batman. So he basically works at night to avoid this photosensitivity because he likes the medications working for him. So we have some patients on posaconazole. I have some examples in the room. This is the time that the others don't work. You have kind of a salvage therapy. We don't use liquids. They don't absorb, so it's just placebo. So we use tablets. I'm sure, I know you guys, it's very expensive. You might get to thousands of dollars. Unfortunately, the level should be 3 to 6, and you can achieve it with tablets. Suspensions are usually not absorbed. It causes QT prolongation, and for sure it can bring your blood pressure up. And I save you the last conazole, whatever it is. It's called Cresemba. We have some data. We have 9 patients on it. It's been recently published with the help of our colleagues in UC Davis, and half of them are doing great. So that can be used. Maybe it would be a future. Even though the last 2 are not having coat-by-coat absorption to the CSF, but somehow it's working. So those can be used also. We do not recommend intravenous amphotericin for treatment of Coxy Meningitis at Kern Medical. So if those don't work, you move on to the next level of treatment, which is intrathecal amphotericin. Fortunately, we have more than 60 years of experience at Kern Medical. You use it, and the patient is really sick. If the patient is sick, don't wait. We're just going to jump on this treatment. If they're pregnant, you can't use azole, because remember, you have to use high dose. You're not going to use that. It's teratogenic. So you can inject it directly to the lumbar area, to the neck area, or you can just reservoirs. You put it on somebody's brain, you put it in the ventricle, or cisterna, or lumbar. We start low dose, we titrate it up. Some people can tolerate as just low as 0.2, some people can tolerate it as 0.9. If they have hydrocephalus, they have so much water in their brain, they can tolerate a little bit more. So we start 3 times a week, and then we taper it down as we go. Side effects: headache, nausea, vomiting, ophthalmoplegia, hair loss, ataxia, paraplegia, neurogenic bladder, and erectile dysfunction. So it's not completely off of side effects, but most of them are transient and are not permanent. So this is a slide that I borrowed from Dr. Johnson. This is just showing of how the reservoir works. This is a reservoir under the skin, and the duct goes into the middle ventricle. And this is just a puncture of the cisternal space directly by using the cisternal puncture technique. And Dr. Johnson is a world-known cisternal procedurist. So, of course, we should have another case. Dr. Chandra knows this patient. 42-year-old Hispanic field worker with daily alcohol abuse. He said, oh yeah. From Lamont, admitted on September 23rd. You remember September 23rd? This is 100 years later. Same day, with confusion. Bilirubin is high, liver enzymes are high, sodium is low, MCV is high. It's not vitamin deficiency, probably alcohol. So we did an LP because it's Kern Medical. We do LP right away. You show up with a headache, you get LP. We don't even ask. Show up, LP, bam, yes? Dale, all right? There you go. Opening pressure was not high. CSF glucose was low. Remember I told you if you want to remember something, glucose is low? That's low. Bakersfield, glucose 12, bam, Coxy. Protein is really high. Remember I told you if it's more than 1,000, there's some obstruction going on. Some RBCs, white blood cells about 600. A little bit of neutrophil. So remember at the beginning it could be neutrophil, but it will shift to the lymphocytes. This is one of those cases. So he's not doing well. His GCS is 9. He's having tube in his mouth. He's being transferred to ICU to Dr. Chandra. Family is in Mexico, unfortunately. Roommate says, oh, he has valley fever. But we don't know even his medications, diagnosis, nothing. His legacy remains as silent as it is, unfortunately. So Kern Medical, we started fluconazole, 1,000 milligram IV. Well, we can't give him oral. We started him on dexamethasone and antibiotics quickly. So these are his CT scan. Unfortunately, as you can see, he starts to bleed slowly a little bit, more and more. 3 consecutive CAT scan shows that he is bleeding into his ventricles. We have no idea. So turning him around, doing a cisterna is not happening, Dr. Johnson. Putting an Ommaya is not happening. No neurosurgeon can put any reservoir in this patient, nor they wanted to watch this. Serum Coxy came back high. CSF Coxy come back high, so this is a definite diagnosis. So he's not doing well. 2 ID doctors, 2 neurologists, 2 intensivists are now scratching their head what to do. So MRI could be done at least after a couple of days. He was more stable. He has leptomeningoencephalitis, enhancement of the layer of the brain. A little bit of a spider, not as spiderish as the other one. And the MRI diffusion showed he had more than 30 small strokes that could be identified. These are all basilar meningitis. It's just showering strokes all across the brain. Fortunately, this patient passed away. We could not save him. So the key take-home message is that if he gets to this point, nobody can save him at this time. So I'm begging and pledging to you guys to start the diagnosis as early as it can make it, because if it gets to this point, it's too late. So I'm going to use this case to give you a little bit of an indication of using corticosteroids in Coxy Meningitis. That's what we do in Kern Medical. That's what I learned from my mentors, Dr. Johnson and Dr. Einstein. We use dexamethasone 20 for 7 days, and we taper it down 4 milligram every other day. We use it for people who are confused up front. We think the inflammation is bad for them because brain doesn't have any capacity to swell. So we're just trying to decrease the inflammation. If they have CVAs, Coxy Meningitis associated CVAs, we use meningitis. We have actually published this data. 221 cases from 6 or 7 centers were collected, and 18 of them had stroke. We put them on steroids, and we were able to protect them from a second steroid. So this could be used also. So take-home message, diagnosis delay and underdiagnosis, unfortunately, still common. Mortality, morbidity is very high. You guys seen some cases. Any suspicious needs to get lumbar puncture and MRI, and treatment is lifelong, as we mentioned. So with that, I have no other slides. Before I introduce the same speaker, or maybe you should do it, Dr. Johnson, because you are the moderator. So this is a case, in fact, this is a patient who came up with a valley fever. What you see here is not Ommaya, it's not a reservoir. This is a Coxy abscess sitting on her scalp. So she wears a scarf, she's a Muslim, so nobody noticed this. She came in with dissemination into the bone and lung, and then we did a bone scan, we saw it here. Fortunately, the Cox is penetrating inside the brain, but sitting on a dura. So we did lumbar puncture, was negative, even though we treated it as meningitis for a little while. I think she's off of treatment, Dr. Johnson, am I right?
Yes.
Okay.
That's 5 years later.
Okay, very good. Perfect. Just wanted to mention that. That's all. Thank you so much. So our next speaker is Dana. She is our Valley Fever Institute coordinator. She is the coordinator of the studies called SAND. She is going to explain it to you how this study works. This is an NIH-granted research project, has been recently changed. The protocol is way easier, so we need everybody's help for picking this up. We already have 5, Dana, am I right? Enrolled, and 6 tomorrow, so we're very excited. With all that, please, Dana, thank you so much.
Good evening. I'm really honored to be here amongst these amazing physicians that I work with. My name is Dana Brucker. I'm the research nurse with the Valley Fever Institute, and I'm here today to discuss a Valley Fever pneumonia study. Okay, I really don't have anything to disclose. Okay. So the formal name for this study is the SANS Primary Pulmonary Coccidioidomycosis Study. We like to call it the Valley Fever Pneumonia Study. It's an observational study to assess the prevalence and outcomes of primary pulmonary coccidioidomycosis in persons aged greater than 14 presenting with community-acquired pneumonia in valley fever endemic areas. The study is observational only. Essentially, what we're doing is observing your treatment as providers. We're not trying to assume your patient's care. It provides data on the prevalence, or we're looking to provide data on the prevalence of primary pulmonary coccidioidomycosis among persons presenting with CAP in endemic regions. So among individuals diagnosed with primary pulmonary cocci, it aims to describe the clinical course, the predictors of the clinical course, compare the response to provider-prescribed antifungal therapy versus no antifungal therapy for primary pulmonary cocci. So the hypothesis to this study is in patients with primary pulmonary cocci, early empiric treatment with antifungal therapy is effective in reducing the frequency, severity of symptoms, and associated adverse outcomes of infection in recently acquired Coxy pneumonia. So this study enrolls in 2 steps. The first step is essentially for CAP patients. We're looking to enroll up to 1,000 adults aged 14 and up that have been diagnosed with community-acquired pneumonia in our area, or all endemic areas. Step 2 is for patients that actually have primary pulmonary cocci. We're looking to enroll at least 200 persons aged 14 and older with primary pulmonary cocci. So the duration of this study, step 1, if you're just diagnosed with CAP, we bring you in, enroll you. You are in the study for about, I think, well, we first do a Coxy test and a few other labs, and then in about 3 to 4 weeks, we bring you in, do another Coxy serology. If you are negative, then your participation in the study is complete. If you happen to test positive for Coxy, we follow you up to 24 months. So in order to participate in the study, there are criteria. It's pretty easy, though. You have to be 14 years or older presenting for clinical care in Coxy endemic areas. You have to have a diagnosis of community-acquired pneumonia established by a healthcare provider. You have to have a pulmonary opacity on a chest x-ray consistent with CAP. Your onset of your symptoms related to your current CAP diagnosis have to be within 28 days of enrollment. For a new diagnosis of CAP and Coxy, enrollment must occur within 14 days of the date of diagnosis. The patient must be able to understand the study and provide informed consent. They must be willing and able to comply with study procedures and complete study visits. Patients must be willing to allow access to medical records and be able to make sure that we are able to access their records. So, exclusionary criteria for the study. You have to have a documented history, or if you have a documented history of Coxy, you do not qualify for this study. I get lots of people calling me, I have Coxy or valley fever, I want to participate. Unfortunately, I have to turn them away because we're looking for a brand new diagnosis. If you've been hospitalized within 14 days prior to the onset of pneumonia symptoms, of course that's probably not going to be a community-acquired pneumonia, it's going to be a hospital-acquired or something. Presence of cavitary lung disease, evidence of disseminated extrathoracic disease, you would not be able to participate. And if it's been greater than 14 days since the diagnosis of your coccidioidal pneumonia. So we're trying to make the referral process as easy as possible. At Kern Medical, our doctors are able to access a consult for a Coxy research team in the EMR, but for outside community providers that we're hoping will help us, it's as easy as calling this phone number here. There's also information, I believe, in your binders on the table. It's a phone that goes directly to me. You can give me your patient's information, or I can come pick it up from your office and then reach out to your patient. If they qualify, then we will definitely be in contact with you. We will need records from you and so forth. So that's pretty much it.
And our last speaker before we do the panel is Dr. Augustine Munoz, my partner in crime with coccidioidomycosis for more years than either one of us wants to reveal. And he's going to talk to us about coccidioidomycosis in pregnancy. Augie?
Boy, the lights are bright. Thank you very much for all of you being here. We appreciate the support. We hope that you can help us conquer this disease. I had this disease myself. I never knew till I got to Davis, and then I became a research guinea pig for Dr. Papagiannis, who was developing a new skin test. And I thought I was going to help him save people because he was taking my lymphocytes and getting transfer factor. Of course, he could never get that much transfer factor out of me. I wouldn't give him that much blood. And we did try it on a young man that was dying in the ICU. But he had ARDS. We didn't give steroids. We gave bitsy bits of transfer factor, and it didn't work. But we're still looking for that answer. So let's talk about Coxy in pregnancy. The simplest thing to do would be, did I go backwards? Okay, this is us. There you go. I did go backwards. Nope. Oh, it's the bottom one. Okay. Oh, that one. Okay. I have, yes. Oh, there it is. Good. Perfect. Thank you. But do I aim there or aim there? Down here? Oh, up there. Okay, that's why it's not going. Okay. So let's talk a little bit of history. First of all, this one? And which way do I aim?
No, it doesn't matter.
Just press it. Okay. So the first time we hear about Coxy, we have in 1941 by Farnese, and he's talking about a single case of a young woman that died during pregnancy. Next time we see someone, it still doesn't work. Oh, there it goes. After Farnese, we have 1951, which is Vaughn and Ramirez, and they presented 28 cases here from Kern County. 5 of them delivered disease prior to pregnancy and did well. 1 of 12 had an infection within the first trimester. 1 of them died. 5 had disease in the second trimester, infections, 1 with meningitis, and 1 died. And 11 with the third trimester infection, and 7 of those people died. What we can see, the risk of severe coccidy gets worse with the trimester. All the cases, the newborns did well, and they had a passive transfer of the antibodies. So they were not injured at all. So we keep going to this. Next time we see someone, we're looking at 1988 WAC et al. In Tucson. They looked at 47,000 plus pregnancies, 3 different health facilities. 10 cases, 7 of the 10 were diagnosed in the first and second trimester, all did well. 3 were diagnosed in the first 10 days after delivery. 1 was self-limited disease, 2 had severe disseminated disease with meningitis. There were no maternal deaths. All the infants delivered were healthy. So we keep going with this. And now we see in 2000 Caldwell, a local paper, our study, 1991, 1994 epidemic in California, 8,435 cases in Kern County, 32 pregnancy cases, 3 disseminated, no deaths. 206, Crum et al. Did a research study of all the literature that was published. 81 pregnancies associated with Coxy. Dissemination, 75%. 10% had miliary disease. 51% had some kind of abnormal chest x-ray with a recent pneumonia. 50% in the first trimester, 62% in the second, and 96% in the third trimester developed disseminated disease. If we keep looking at Crum's data, he looked at a specific group, African American women, 13-fold increased risk of dissemination. 81% of these women had the disease during pregnancy. 9% had it after pregnancy, 10% before the pregnancy developed. The survival for the mothers was only 64%. The survival for the infants was 69%. That's much worse than what we see now. So this was what brings it up. This is what the problem we had to think about. So what are the reasons, the predisposing factors for this? Pregnancy is a state of relative immunodeficiency. There's a depressed cell-mediated immunity. We have a shift away from the Th1 response to protect the fetus and the placenta from immunologic attack by the mother. We have a direct stimulation of the growth of the coccidioides resulting from the high levels of estradiol and progesterone in pregnant women. This has been studied. There's some elegant studies. You can see those endospores growing fast and furious with this hormone. Men normally are more likely to have dissemination because our hormone level is high unless you're competing against a pregnant woman. In that case, her hormone level is higher. So what are the things that promote this? The thick outer hyphal wall of arthoconidia prevents phagocytosis. Again, this is a paper published by our group. You can see down there. What else do we see? Each spherule produces hundreds of endospores compared to only 1 to 20 daughter cells that you see in a classic fungal infection. So you're talking about they're bringing all of the armed forces in armored cars, and there's a gang of them, not just a few, a lot. There's a fibrillar material that's released from the spherule that surrounds these endospores and prevents the polys from getting access to these little critters, and so they can't get rid of them. This is, I'm not going to talk about this. This was in 2011 and was published in CID by the Infectious Disease Society, but there's a better paper, which I'm going to talk about, that was published in 2016, okay? And before we can talk about that, let's just see what happens if you get azoles. You get this Antley Bixler type syndrome. This is an actual problem that occurs without Coxy if you have a mutation in the cytochrome P450 or you have a mutation in the cytochrome P51. Both of those are going to affect certain enzymes that cause these changes. There's 5 cases of people receiving Coxy in early pregnancy, a high dose from 400 to 800 milligrams a day, and they get this craniosynostosis, and they get the skeletal abnormalities involving the elbow. You can see there the elbow, I don't remember which one of these is the arrow, but you can see the elbow's involved. Animal data shows the same thing. All of the azoles will do it, and voriconazole in particular is worse, okay? Now, later on, and you see there the reference below, CID, the Infectious Disease Society in 2016, says that you can use azoles probably safely after the first trimester. But these are the things that we have to talk about, and I'll show you where that evidence came from. So, and this is hard to read, but this is, the IDSA uses 2 points to grade. The first top part shows you how they're looking at the data. So you get the research data, and you're looking to see what kind of a paper it is. And you can see at the higher level, it's a randomized control trial. Below at the bottom level, and we're talking about up in the left-hand corner, that this is just more like an observational study. So there's less accurate, less reliable data as you go lower on this. Now, they take this paper and they start out with a certain level of confidence. Then you see the middle part of that slide, on the top part, there's things that improved the effectiveness of that study, and there's things that reduce the effectiveness of that study. So if that study is meaningful or not depends on whether it's you got good correlation of the data, whether there's a lot of ambiguity, whether things don't mix and match the way they should. And you can see then that there's ratings on the validity of that study to prove its point, that this helps or it doesn't help. And so it's rated, and you can see the rating. The bottom half of that slide shows how they come up with a recommendation, and they look at several things. They're looking at 4 different aspects from the people's standpoint. And so then they rate it as strong or weak. Strong means that you would recommend it, you would even make a policy. Weak means that you'd have to do a lot of talking about it, whether it's good or bad. So then let's move on. So you have a symptomatic patient with Coxy and they're pregnant. You have to think about starting treatment immediately. You can't put this off. What happened to my pointer? So non-meningeal disease. You must consider the fetal maturity, strong recommendations, moderate support from the research. You want an initial trimester, you give IV amphotericin B. Strong recommendations, moderate research support. Alternative, close monitoring without treatment, weak recommendations, low support from the literature. Azole treatment after education about fetal effects, again, weak recommendations and low literature support. After the first trimester, azole antifungal, strong recommendations, but again, low support from the investigations. Amphotericin B throughout pregnancy, weak recommendations, but a very moderate response from the literature. Symptomatic coccidioiditis during pregnancy. Come on, baby. Go. There. Meningitis. First trimester, intrathecal amphotericin B. Strong and moderate. That's the best recommendation we have so far. After the first trimester, azole antifungal, fluconazole, or itraconazole. Strong recommendations, but low support from the literature. History of prior Coxy not on therapy. You have to look at the risk of reactivation. Is it low? Then no therapy is recommended. Strong and moderate. Close follow-up indicating serology on the first visit and every 6 to 10 weeks afterwards. We usually do the 2 together if we're going to do something. Strong and moderate. So during pregnancy, oops, I went too far. Let's see if we can go back. On Coxy Meningitis, on azole therapy when pregnant. You can stop the azole during the treatment, first trimester, strong and moderate. Administer intrathecal amphotericin B, especially if they have meningeal signs, strong and moderate. You can restart the azole in the second trimester, again, weak and low. Alternatives. Continue azole therapy throughout pregnancy. Educate about the fetal toxicity, risks, and benefits, weak and low. Final alternative, stop the azole, monitor closely during the first trimester, and restart azole during the second and third, again, weak and low. So what about neonates? No serologic testing during the first trimester, okay, because they're going to have that passive result from the mother, so strong and moderate. Empiric treatment if you have to, 6 to 12 milligrams per kilogram, daily suspected Coxy infection until you can rule it out. Strong recommendations, but low support. Breastfeeding, not recommended. Strong and moderate. So these are the references. These are the people that help us do our job. Without them, we wouldn't be able to do it. And of course, there I am looking over their shoulder. And I'll leave you with these thoughts. New study at Kern Medical, possible effect of chitinase deficiency in disseminated third trimester pregnancy. Maybe the chitinase drops. That helps kill Coxy. Our levels, we don't understand about it. We have to look at it. And we're starting an ongoing 10-year review of our Coxy cases so we can see where we are now compared to where we were then. And then I'll leave it there. And I guess we will have a panel group. And I think I probably already went past my time. I appreciate your indulgence. Thank you.
So now I wish I could see you. I think I'm going to have my trusty colleagues have to run around the room with the microphone because I can't begin to see any of you to point at them. So we will now be happy to take questions. We'll try and direct them to the most appropriate people. If Dr. Munoz wants to come back, and Rasha. And if we have a question about the SANS study, we can direct it to Dana. Okay? Well, I don't know if, I don't want her to fall off the stage.
No, I'll stand.
It's all right. I'll.
She can sit, I'll stand.
We have space. We have space.
She's good. Can't see anything.
Yeah. So for those of you that are out there, we're really lit. So do we have a question somewhere? I can't see any of you.
One over here.
Right there.
I have the mic. I'm running.
Boy, this is terrible. This is worse than giving the talk. 'Cause you
So
can't-
I'm sorry if I misunderstood, but I wanted to go back to the indications for, or the guidelines for treating primary pulmonary cocci. Considering the risk of dissemination, particularly to the meninges, when you're talking about lifetime treatment and the high risk of mortality, I'm surprised that the threshold for treating primary pulmonary cocci isn't much lower. It seems like the threshold was pretty high.
And this is exactly what the experts here are doing compared to everywhere else. Actually, at Kern Medical, the threshold is a lot lower than everybody else and anywhere else. If you look at Arizona or even the IDSA guidelines, they do not treat a lot of the people we treat here. So, I agree with you.
So, yeah, I agree with you too, wholeheartedly. And while I was a co-author of the IDSA guidelines, I wrote the meningitis part. I stand behind that. I didn't write the pulmonary part. And the other thing that we don't really know about is that was written by, I think, Tony Catanzaro and Janice Blair, but I'm not absolutely certain. Janice Blair is in Phoenix at the Mayo, and Tony Catanzaro's at UCSD. I can't be absolutely certain what their cocciserologies are. Cocciserology in Arizona is much dicier than it is in California. So when they say the titer's 1 to 16 or 1 to 64, if you're using Quest laboratories in California, we might agree with that number. But our cocciserology would be 1 to 4 in that same patient. So the real way we decide whether we're going to treat somebody with coccidioidal pneumonia is we look at their underlying risk factors, age, sex, ethnicity. We do use the cocciserology. We look how bad's the x-ray, how symptomatic they are, and then we make a decision. And I would say we treat 90% of people that are diagnosed with acute coccidioidal pneumonia. The only people we don't treat are very low risk. They're almost all women, they're almost all young, they're almost all Caucasian or Latino, and they have a titer of 1 to 2 or 1 to 4, and they have a little tiny infiltrate on their x-ray. That person, we discuss risk and benefit, because we can't absolutely tell who's going to disseminate, because that's hidden in the genetic code that we haven't broken. And then after that discussion, we decide to treat or not treat. And in the case of children, by the way, I hardly find any parents that don't want their child treated, no matter how their risk profile looks.
Royce and I are back from the day when we didn't have a treatment except Ampho, and so we would watch these people agonize. We would agonize with them on when to start and what to do. And when we first saw keto, we thought that was going to save a lot of people, prevent a lot of misery. And it did help, but we've always been quick on the trigger because you can always stop the drug. You cannot necessarily stop this infection once it gets started. None of the medicines kill it except amphotericin. The rest of them just maim it, and it's still the immune system, as Dr. Johnson said. So I, for one, would rather be on the safe side. I can always stop the medicine. I would rather start it and make sure. And I'll tell you, we have better results overall in a lot of our patients than they do in other places because we're always looking for this disease, and we're ready to treat quickly and aggressively if it's necessary.
Thank you, Dr. Munoz.
Thank you all for a very nice couple of talks. And I do want to just mention that I'm from Kaiser Permanente, and we are the other center in town doing the NIH study. And there are 5 centers, including Fresno, by the way. But my question is along the same line, possibly for Dr. Karan. One of the slides mentioned a titer of 16, titer of 64. In that particular recommendation, I guess you would call it, the 16 is you possibly would only treat them if they're very symptomatic. And the 64 is even if they're not symptomatic, you would treat them. Is that how that works?
Yes,
Thank
if it's 64, I definitely would treat. If it's 16, I would think about treating very, very hard. And this is actually what's published and what's recommended in the literature. But then again, our practices here are more, the threshold is lower. We even treat if it's as long as there's symptoms or with other risk factors. So.
Again, I would definitely agree with the previous speakers. I think the load of the disease in our community is different from Arizona. I think we have more field workers. I think they get the most, maybe a bit overburden of the fungus also. The access to care is an issue. You don't have a way to monitor these people closely. So if you treat anybody even with a very low titer for 3 months, none of us in this podium will be angry at you at all. In fact, we will appreciate. This will give you enough time to follow these people, see how they do. If the infiltration goes away, if they're symptomatically improving, then that would be the time to stop it. As Dr. Munoz mentioned, we can stop it any time. But restarting it when it's meningitis or it's dissemination is basically devastating. So we don't want to roll the dice, see who will get there, who will not. So we recommend our guideline is to treat and just observe and stop later. How about that? That's my 2 cents.
Hi, I'm Dr. Ashraf. I'm a local pulmonary critical care. So question is that some of the patients who have disseminated disease because they're on biologic or immunosuppressive medication, I mean, when do you let them go back to have that medication again? And what's your strategy when you're treating these patients and what dose you keep on? I mean, so far, I don't have any guidelines except just keeping on unlimited time altogether because these patients, most of them had ended up having a disseminated disease. So.
That question is too hard for me. I'll give it to Dr. Haidari.
Thank you so much. If they're going to be continued on one of the maps, because there's a lot of them out there, if the serologies are stable, maybe reduce the dose to a non-toxic because there's a drug-drug interactions in those situations. I'll keep him on 400 until God knows hell freezes. I don't know. I'm very afraid of stopping treatment, to be honest with you, because those definitely will add on to the genetic problems they already have. We were in the Stanford when they were presenting a case, somebody was in infliximab, titer was 1/16, and our colleagues in Arizona were just watching this patient. I was just looking at Dr. Johnson, are you really serious? So I would say if you better be on the safe side and keep him on a fluconazole, I think that's what my recommendation is.
So most of the experience is really with TNF alpha inhibitors. And TNF alpha, which produces the fever and the weight loss and all the bad symptoms that we get from having inflammatory disease, also is the chemical that keeps the lymphocytes, CD4 and CD8 cells and macrophages arrayed around a coccidioidal organism. So when you block TNF alpha, it's like you took the sheepdog away from the sheep herd and the sheep begin to wander off and you no longer have an immune response to that sphereal. And remember, we don't kill Coxy. So as long as they're on a TNF alpha inhibitor, or even worse, an IL-17 inhibitor, and I don't know the mechanism as well, but IL-17 is absolutely key to Coxy. You can't come off of an antifungal drug. Now, what's the right dose? I don't know. And remember, most of these people actually are immunocompromised before they took these drugs. Having rheumatoid arthritis or lupus is bad enough. and then you add this on top of it, these people are a potential red-hot mess, and they will escape and become disseminated in a flash if you're not watching them very closely. And so we don't stop, basically, under most circumstances.
Hi, this is Andre Farr. Nice to see you all again. I was at the...
He's following us.
Absolutely.
We were at Davis, and he was there. We were at Davis last weekend. We come home, and lo and behold, he's here.
He's here. Yeah, I've become... You guys are rock stars to me. I'm your groupie. I'll be going everywhere with you guys. And honestly, as I'm the chairman of the Sports Agents Association. We represent the majority of players in the NFL and NBA. And tonight we have this Laker finale that's in Los Angeles that I was supposed to be at. And I told my guys, I'm going to see some rock stars about valley fever. And so I drove here. And the reason I'm doing this is because I was diagnosed with valley fever. And I was in the hospital for 21 days. And it kind of blew my mind and my family's mind. And I am so convinced now that we need to have an awareness campaign for valley fever. And I would like to use our athletes and our high-profile celebrities to get this awareness campaign out, via social media and live events. And I think we should push for testing for early diagnosis and also, try to raise some money for research, vaccine, and possibly a cure for this. I think you guys have been doing a wonderful job for so many years. Just need help to get it out to the public. So I want to thank Charlene Worthy for, thank you back there for inviting us, for Jay and I, and we're going to do whatever we can. So we're going to be your groupies for a while. So we look forward to working with you all.
We appreciate you being here. Thank you so much. So I might feel a little insulted that he thinks LeBron might have more public eye than I do, but I'll take it. So do we have more questions out there?
Yeah, right here. Kyle Heber, and I've actually been following them around a lot longer than you. Dr. Curran, I've only gotten to know the last 9 months working in primary care, but Dr. Munoz and Dr. Johnson, I trained under them as a medical student at Kern Medical years ago, so glad to be back. Question on terms of diagnosis. I noticed in the guidelines you guys were mostly, were hinging on the CF titers and immunodiffusion, and also the histopathology if you can find it in tissue. But you guys really, there's not much focus on Coxy PCR. I'd use that a lot in my residency, especially because if I was getting tissue, PCR would come back faster than tissue or any serologies. But is there, problems with the validity of the testing that you're aware of, or a reason that we shouldn't be using, or is it difficulty with availability of the testing, or?
You got the answer in the last sentence, availability. We don't have a PCR for human. All the PCRs that are available are homemade, and they're not FDA approved, so they're only available in certain centers. Where did you?
UCSF Fresno.
Yeah, UCSF Fresno is one of the very few places that has a PCR. We are thinking about doing research with Joe Wheat at Mira Vista. In fact, we're trying to put together an R21 grant to do a cross-sectional analysis of all the diagnostics, and including a new PCR that he would build at Mira Vista. But there is no, as far as I know, I could be corrected by somebody, but there's no commercially available PCR, and there's no PCR for people that lives in Bakersfield. Dr. Lauer has a PCR out at Cal State, but it's for dirt.
So they've essentially just been developed by whatever lab is using them. They develop their own PCR assay. Got it.
See, for us, the best thing is the people that I showed you next to the last slide. Those ladies looking in the smear of a bronchial wash, a BAL, they're going to find it within 10 or 15 minutes after I do the procedure, and they're going to see those spherules, and we're going to find them, and we're going to know that it's time, and we do it right now, right? They're probably already on treatment before I get called, because that's how trigger happy we are if they're that sick, okay? If they need a bronch, they're that sick. And then because we're vigilant, and we are vigilant, within a few days we have a little tickler on our computer system says young fungus. That doesn't mean anything but Coxy. And then sooner or later we can actually see it. And I have some really good pictures of those over the years, including that picture that Dr. Johnson showed you that looked like cancer. It was Coxy.
Other questions? Yes.
Sorry to take another question. Going with what Dr. Heber said, I'm wondering if only PCR should be valid on a tissue biopsy. If you try to do a blood or something, half of us will be positive. So is that true, or?
We don't have great data about this because there isn't that much PCR, but I'll let Dr. Haidari answer because we both talked about this, but early in the infection, I mean, PCR is basically a way of looking at antigen as opposed to antibody. So I think our suspicion is that early in the illness, remember the antibody doesn't come up for only 50% of people that show up with CAP that have Coxy have a positive serology at presentation, 50%. So it takes a few weeks to show up. It is quite probable, I think, that in those early days that PCR could be positive in blood and or bronchial fluid. I suspect as the disease goes on, the sensitivity of the PCR goes down, the sensitivity of the antibody test goes up.
Yeah, same. Unfortunately, there's not much literature out there. Most of them are case reports. And I would encourage if your center can actually come up with a case series, show us the cases that the early antibody is negative, immunodiffusion by PCR is positive, so we can validate that. Unfortunately, there's not much on the literature that supports us to spend that much time. And also, the turnover for us is almost as the waiting for the immunodiffusion for us because we don't have it in town.
I may add, last weekend at the Coxy study meeting, we saw some really amazing research, one coming from University of Modesto, lab people where they developed a test, a breath test, very accurate diagnosis, active Coxy infection, and another lab that was working on urinary metabolite assays, and they did really well. It's just a matter of getting them commercially available, hopefully, so we can use them.
All right, I know we're running long. Here we go. We have a question over here.
Is there anything we can do to prevent the disease?
Move to Alaska?
What?
Prevention.
You know, if you live in Bakersfield or if you live in the endemic areas, I mean, you're likely to get it. I mean, what can you say? The only way we're going to do anything about this is get that vaccine, just like we did for other things. And hopefully we don't get a bunch of radical people saying the vaccine's going to make you do something, so don't take it. I mean, but it works. I mean, we have enough people that have gotten the disease and are alive and well and don't have any sequela because their system works. We just have to figure out why that works and how we can duplicate it for the rest of the people. And, you know, I'm one of the living people. My neighbor had to spend a whole year out of school, homeschooling, because she was sick from the valley fever. She didn't die, she did fine, but she was sick for a long time. If she would have had any other problem with her immune system, and again, we don't understand that. There's a long ways to go. Until we started this research on the valley fever vaccine that was started here because of the money we raised here. We didn't even know there was 2 forms of Coxy. We didn't even know that Coxy had sex, and it does. So that just means it's more likely to survive different things. It can select itself to be better and better. So we're learning those things because we spend time and money. And I hate to say that, but we need that money, and we need everyone's support so we can understand it. So we're here with our little dog and pony show trying to get your support so we can't do this alone. For 40 years we've been struggling. I've been struggling at Kern Medical Center to do the best I can against this. First with nothing, using a scale to decide who gets treated and who doesn't get treated, to jumping up and down on ketoconazole and thinking that was the best thing ever, and no. And we still have nicomycin that hasn't even got off the bench. So there's a lot of stuff that needs to happen. We still need to get that answer. This is a really smart, tough bug. and we have to figure out a way to get rid of it. So we're employing all of you to help us. I mean, this is not you or them, it's us, all of us. And it's not just here. The more we investigate, the more we find this valley fever. The more we look at the soil, the more we look at the climate, the more we look at the temperature, all those things tell us that valley fever could live different places. We just haven't seen it.
All right, any other questions?
Well, hearing none, I want to thank Candace, Charlene, Erica, all of you over there. Please stand up. Can we have a hand for them for putting this together? Okay. Well, thank you all for attending. I think this is a good start. It's our intent. I don't know whether we make this an annual event or what we do with where we go with this, but it is our intent to have a much higher public image for our fungus locally and throughout the state as we go forward with the Institute. Okay, thank you again very much.
Thank you. Make sure you turn in your forms right over there at the registration table so you make sure you get your credits. Thank you.
You guys are all deputized to go out and fight this fungus, so get with it.
How are you?
This is 40 years old.
Awesome.